On today's show, we're going to be talking about bipolar disorder, a psychiatric mood disorder characterized both by periods of very high mood and very low mood, hence the name bipolar. In the interest of openness, I'll state that my own diagnosis is bipolar disorder. I'm joined by two guests who have experienced this issue in their lives. Robert Villanueva lives with bipolar disorder. He tells his story publicly as part of NAMI's In Our Own Voice program, and he trains others to tell their stories, and he even trains the trainers. Welcome, Robert.
Thank you for having me.
Dr. Po Wong is a board-certified psychiatrist who works at Stanford. His specialties are bipolar disorder and psychopharmacology, and as such has treated many people with bipolar disorder. He is part of the Stanford Bipolar Disorders Clinic. Welcome, Dr. Wong.
Thank you, Barbara, for being here.
Robert, I'd like to begin by having you tell us your story. Sort of what did you do before in your life before you had bipolar symptoms, and then what happened?
Yeah, that's fair. I grew up actually right here in the East Bay. Grew up in Castro Valley, went to Castro Valley High School, and wrestled in high school. And after high school, I became a wrestling coach, so I worked with kids and got married when I was probably about 24. I have a wonderful stepdaughter who just got married recently, and I was coaching and a garbage man for about 13 years. Before I really became symptomatic and my life got disrupted.
So, when did you first experience the symptoms, and how did you know that something was wrong?
Yeah, I was probably about 28, and I just noticed that my sleep was really heavily affected, that there was periods on end where I would sleep, wouldn't be able to get to sleep at night, and I call it like kind of my brain would be spinning, and just thoughts constantly racing through my head, so a lot of racing thoughts, followed by other periods of just wanting to sleep for 3 days on end, and I would call it the 3-day flu, but I wouldn't have any other symptoms, but just could not get out of bed, and so I think that was the lows of my bipolar disorder.
Right.
I recognized and sought out help.
Okay. So what did the high mood feel like? What did you do that was out of character for you?
Yeah, I remember it started off, probably, as I mentioned, I couldn't sleep at night, so I would be up at anywhere from 2, 3 in the morning, and just I could not shut down my thoughts and sleep. And actually, in my experience with hypomania, which is a lower level of mania, it actually felt good. It was very productive. It was, I can mow the yards and take on a couple jobs, and just a really productive period. But then it would move into a more manic period, which was, from the lack of sleep. I would have delusional thoughts, like one point, maybe thinking I could run for mayor or something, and that would last a week, and I would almost put a campaign together. Other times it would be just taking on too much, thinking that I can take on 2 jobs, or getting overcommitted, and just really not stopping and focusing on day-to-day life. So,
right. Yeah. Any spending of money or any other risky behavior?
Yeah, it's funny you asked that. Yeah, I know one period after the 3-day flu, I got up and I had this compulsive thought that we needed to buy a convertible, and I'd never thought about it before. And I kind of took a shower and got my wife together and said, "Hey, let's go look at cars." And she kind of looked at me stunned, but she kind of liked the idea. So we went down, and by the end of that day, we had traded in her car for a convertible little Celica that was kind of like a purplish blue, something that I would never pick. And we actually drove away, and then, there was 3 days later when I looked at it and said, why did I buy a car? I just didn't understand it, but yet kind of justified it, found a way to justify it in my head. So that was definitely a manic decision and moment.
So when did you decide to seek help for it?
Probably, originally I was diagnosed with clinical depression because of the sleep. I started missing work, which was very rare in a 7-year period. I never missed work, and then I started missing work and started isolating and withdrawing from the community and family, and when it started really affecting my family, and I honestly, I thought I had like a brain tumor or something. I was scared when the phone rang. I had anxiety, I had isolation. So I got to the point where it just was affecting, it was obvious how bad it was affecting me. But people outside the home didn't know. You know, I wore the mask and nobody, you know, I didn't reach out or anything. So I went to the doctor to talk about the sleep problem. And that's when I was diagnosed with clinical depression.
Okay.
And then 2 years later, I was diagnosed with bipolar disorder.
Okay, so it sort of took 2 years to get to the correct diagnosis.
You know, and I was taking medication and going to a therapist to try to work things out. But we really didn't get a true diagnosis until a couple of years later.
And then after you got diagnosed, you probably were able to get into a more regular routine.
Yeah, it's whenever I actually ended up the way I got diagnosed was I ended up in the hospital in a psychiatric unit. So they were able to monitor me over a period of time and ask more in-depth questions. And I think for me, I was able to. I remember I learned more, so I was able to communicate better what my symptoms were and identify different symptoms. But you know, it took another probably 2 years after that to really get stabilized. And you know, at that point, I had lost my family and my job, my career, and had really. I was basically living in the back room of a good friend's house, just you know, still struggling and trying to find some answers as far as what I was dealing with.
Dr. Wong, can you tell us what the characteristics of bipolar disorder are and how they relate to Robert's experience?
Yeah. So we use the word bipolar disorder now, and that's fine to use that word. In the past, it was called manic depression. So they're the same exact thing. Manic depression is probably an easier way to understand what bipolar is, because it's manifested by mood episodes. And the mood episodes are at extremes. So some people have manias or mood elevations, and some people have depressions, and they happen at different times in people's lives. Manias and depressions are all moods, and that is different from like emotions. So emotions are things that we have experiences for circumstances that make sense. So you win the lottery, you're happy for a few days, and then you're worried, that kind of thing. Whereas mood is more of a full body experience that just sort of comes on. And as Robert said, he thought he had a brain tumor because probably his mood was so profound that it was kind of not making sense to the situation. So that's what really a mood is. And so bipolar disorder is a mood disorder. And with, for instance, the manias, those periods of time are mood elevations. The mood component means that you have things like euphoria, feeling excessively happy. And it's not just feeling happy. You know, some people are dancing on tables, or you know, they're trying to run for mayor or things like that. So kind of extreme, you know, happiness in that way. And some people get really irritable. So these are the gateway symptoms of of mania. But because of the mood, meaning it's a full body kind of experience, there's a lot of other things too, like people talk faster or their thoughts going faster. And because of that, maybe they're distracted, can't stay on task. And maybe because of that, they're starting a lot of projects, things like that. So those are kind of the symptoms of mania. It can be so bad, as it sounds like in Robert's case, where it causes a lot of dysfunction. And that would be considered what we call mania. And if it's a little bit less than that, where people might notice is a problem, but they might not end up in the hospital or call the police or something like that, or call a psychiatrist, that's what we call hypomania, hypo meaning less. It's still significant. It's still not normal. And people might like it, but it's still not considered just normal. Okay? And that's the mania or the mood elevation or the hypermania, that part of it, mood elevation, is what is sort of classically defining of bipolar. But from day to day, most people are actually depressed. So depression is the other component of bipolar illness. And depression is kind of similar to other forms of depression, like when people have just what we call unipolar or regular depression, or when people get depression from Parkinson's disease or from some kinds of cancer or brain tumors or those kind of things. That's the same kind of depression. Again, it's a full body experiences. So it's sadness, lack of interest, sleep problems, appetite problems, moving slowly. Sometimes people have suicidal thoughts. So it's all these kind of things put together. And even though bipolar disorder is classically defined by the mood elevations, most people have more problems with the depressions.
Yeah, that's where they come to seek help, probably.
Yeah, I think, and Robert gave a great example of that, where you know, nobody ever thinks it's abnormal that they're, you know, feeling good about themselves and they're being productive and have all these ideas. And if they thought that was unusual, they'd still kind of like it. It's only when, you know, they're in these prolonged states of not enjoying things and not being themselves and not getting out, and people going, that's not normal. that they finally go, okay, I got to do something about this, and that's where the depressions come in.
Well, what's the difference between bipolar I and bipolar II?
Yeah, so they're very similar in terms of like the fact that there's mood elevations and the depressions, and the depressions are basically the same. Okay, the big difference is really the degree of mood elevation, and so in bipolar I, the mood elevations are called manias, so meaning that they're very severe, and severity means like people might end up in the hospital, or they might actually get so elevated that they lose touch with reality. So things like their self-esteem might go through the roof, like, you know, I'm going to run for president next year. That's not going to likely happen, okay? Or, you know, I'm going to win the Nobel Prize next year. You know, everybody wants to do that, but maybe not next year, okay? Or they don't need to sleep days on end, which is not usually very possible. So that's what we call mania, markedly severe. When it's less than that, it's called hypomania, and that's bipolar II.
Okay.
Now, I should point out that people with bipolar I, they can get hypomanic. It's just that they have some propensity to get manic at other times. And the fact that they can get really, really, really elevated puts an extra warning for us, so that we have to respect the fact that they have that propensity, and we call that bipolar I.
Okay. And what about, my own diagnosis is bipolar not otherwise specified.
Yeah.
And it basically, the characteristics are, you know, a little blip of high, you know, functioning, or very high functioning, and then deep depression if it's not treated. That's what the characteristics are. And it started out with a depression, which was postpartum depression, and then several years later, you know, I noticed these little blips that would come before any depressive episode, and my psychiatrist decided that my diagnosis was not otherwise specified, you know, part of bipolar disorder. Yeah,
the simple explanation of NOS, or not otherwise specified, is it's not one or not two, bipolar I or II.
Okay.
But what it really means is, from a clinical or from a prognostic standpoint, is that there's some vulnerability to bipolar illness, or for more practical purposes, there's some vulnerability to mood instability. Okay. And what that means is that you might be more sensitive to certain medications like antidepressants. Okay. So when we come right down to it, the main reason this is important is because when people come in and they're depressed, okay, are they majorly depressed, or are they having a bipolar depression? Because the treatments are different. Now, there's a lot of people get treatment for depression, whether it's bipolar or not, that just get antidepressants, and that's sort of the general consensus out there. But that's not the way we're supposed to do it. We're supposed to treat bipolar depression like the bipolar depression, and regular depression like regular depression. So antidepressants, for instance, might be effective for regular depression, but maybe okay, but maybe problematic for bipolar depression.
It might throw someone in a depression into a mania.
Yeah, that's the worst, where it throws them into mania. And equally bad is that they're just treated for 10 years and nothing helps. You know, and you know, there's only so many antidepressants you can give before you just go, well, let's think about what the diagnosis is.
Now I'd like to talk to some about what kind of treatment that you received for your illness, and how long it took before you found something that worked. I think you said a couple of years.
Yeah, that's one of the big questions I get when I do presentations. And I tell people that I've actually been on 14 different medications throughout the years, and you know, a lot of it's different dosages at different times, and so it was a long process. It really took probably a good 4 or 5 years before I really found a good combination. I have medications that are PRN, so as needed, so as needed for sleep, because during my more up stages of the bipolar disorder, I need something to help me get to sleep, to shut down those thoughts. And other times, I may not need anything to get to sleep, and also to get up and moving and go about my day. I may need something to help me get kind of kick-started for the day. And it's all monitored with my doctors and therapists, and definitely. So it's and treatment isn't just medication for me. It's also getting out and socializing when I don't feel like socializing, or coming home and going to sleep when I feel like socializing too much, and you know, so I really have to monitor my sleep as a big part of my treatment.
So you said that you had lost your family at one point, and how did you get your family back?
Yeah, well, unfortunately that didn't work out, but yeah, so I did lose that part of my life, but we're great friends and everything. But it was just because I was dealing with something I had to go out and kind of find out what the bipolar was. But it had a lot of damage, and it was a long process getting back into recovery. Once I got stabilized, I always thought that everything around me changed, but it was me that was changing in and out of moods. So once I realized it was me, then I could make better decisions on dealing with my family and following through and not overcommitting. And so, yeah, I was able to repair all those things with my family now that I'm able to monitor my moods better and make decisions. And
so you do things besides the medications. It sounds like, you get exercise.
Yeah.
What are some of the other things you do besides?
Exercise definitely is important. Even when I don't want to go to the gym, I go to the gym. Sometimes I just steam and, definitely. And I show up is a big thing. Because I know normally in a normal state, a normal mood, I like going to the gym. So definitely. I have a lot of coping skills as far as recognizing red flags. So for me, that means that if I feel myself on a Friday evening getting more active and having more great ideas and wanting to spend money, I have a friend that I give him my credit cards, and I say, you know what, I think I'm getting a little hypomanic and I don't want to move into that manic stage, so I'll give him my credit cards and I'll kind of make sure I put myself to sleep that night and not go out socializing.
That's very nice.
And in one instance, I actually wasn't able to attend a wedding of a really good friend because I just knew it was an evening wedding, and I was really getting, my mood was elevating, and it was the healthiest for me to shut it down, basically, like Dr. Wong had mentioned, not letting get that hypomanic go into a manic stage. So
you do physical exercise, and you do a lot of good work with NAMI, sort of meaningful, productive work that you think is important, is important.
Yeah, definitely.
So that's all. I think that's also a part of getting better, is liking what you do with your life,
Yeah, and I've talked about that with a lot of people that I think by me giving back to the mental health community and going out and speaking and being open with my diagnosis and educating, it helps me stay stable. I know my barber told me.
It helps the people you're talking to, and it helps you.
Yeah, definitely. When I do my trainings, I spend a weekend with, usually 16 consumers or clients, and teach them how to tell their story in the inner own voice format. And during that weekend, I get more out of it than they do. They think, I just walk away and I meet amazing people and see what they've overcame and how they've achieved, and they're in recovery and they're thriving in recovery with their families, and and it's a holistic kind of model of exercise and medication and therapy and family support, friends. Good diet, service, sleep, hygiene is very important for me, I know.
The whole you.
Yeah. And education is huge. I know, Stanford has the education days annually, and for me to learn more about the medication, about the therapies, about what's going on in the mental health community empowers me to communicate better with my therapist or my psychiatrist or, even others. It's definitely that education is just so important for me to be able to communicate. And honesty, that's my huge one, is becoming honest with my doctors. Yeah, that's when I think I made that turn, is when I was completely honest with my doctors and family, and just said, okay, this is what I'm dealing with. So.
Dr. Wong, can you tell us what kinds of therapies you use with people with bipolar disorder?
The therapies are pretty broad now. In 1994, I could have just said 2 things. That would have been easy. Now there's so many that it's easier to group them in categories. And so I think that Robert gave a good example of how we should think about these things. So there's pharmacological therapy, so medications, and that's one big group, and there's things in that class which we can talk about. But then there's also the psychotherapies, and that's a big group. That includes things that, a talk therapist, but it also includes a lot of things we can do ourselves, which is really what talk therapy is for. It's to help you sort of retrain some of these behaviors, like going to sleep at the same time, maybe changing some of your negative thinking patterns, maybe constructing some positive patterns, things like that, enlisting family members. So that's all the therapies, okay? And so there's a lot of things there. In terms of medications, there's a lot of options there as well, and I think there's ways to group that. One way is to group it into mood stabilizers, things that help stabilize mood. And for bipolar disorders, those are our main options, really, because as we talked about before, there's manias and there's depressions, but really what we're trying to do is treat the bipolar as a whole. So mood stabilizers are the main thing, and there's a whole group of medications in mood stabilizers, and there's always new ones coming out. The lithium was the first one,
Yeah,
Okay.
I take that.
Lithium is, it's old,
Yeah.
and people think, that's old, that must not be very good. But the thing is, there's a lot of history with it, and there's a lot of data with it. And there's people that, people show up in my office, a couple times a year, and they go, I've been on lithium for 40 years, and I just want to know if there should be anything else. But they're doing fine, and I say, no, there is, but you shouldn't change.
Yeah.
And there's a lot of new medications, but I think the key is that you have to have a good psychiatrist to figure out, which medications are exactly right. Unfortunately, we don't really have a blood test to figure out which one is exactly right.
Yeah, wouldn't that be wonderful if you could just come and get build a little bit of your DNA or your blood or something? Say, okay, now we know how to treat you.
Almost.
Someday maybe.
Yeah, it's getting there.
Yeah. I take a combination of lithium as a mood stabilizer and an antidepressant that works with that depression. And for me, for my particular, form of bipolar, that works.
Mm-hmm.
So.
It works for a lot of people like that. And then, it really, in the past, that's the reason that bipolar was separated out from some more serious mental illnesses like schizophrenia. They're both very serious, but in the past, when there was a lot of institutionalization in the United States, one of the big ways that people got deinstitutionalized was because of the discovery of lithium and finding out that lithium worked for half those patients that were in institutions, and they had bipolar, and then they could, now they're better.
Is there any special consideration for multiple drug interactions? It must be difficult to do that as a psychiatrist, to figure out what is the side effects and, what is the drug doing and that kind of thing.
Yeah, they're, each drug they're all very complex, because they all do a lot of things. Okay, when we think of, like, for instance, Prozac or things like that, we think that they only do one thing, but they actually do a lot of things. And our body metabolizes these medications in numerous ways. So actually, a lot of drugs interact with each other. Lithium is actually one of the simpler ones because it just goes to the kidneys. But besides that, everything else interacts with each other. Okay. Now, the interactions are generally not that significant. Okay. Now, there's whole books on these interactions, but generally speaking, they're pretty not significant. There's just a few that are more significant, and so as a psychiatrist, we try to keep track of some of those things. On the other hand, though, there are some side effects that are sort of additive. Okay, so because all these drugs go to your brain, because otherwise they wouldn't work, right? They all have common side effects like sedation and tremors and memory problems, those kind of things. And so we have to sort of balance those medications. And the easiest way for me to do that is usually I sort of think about what benefit this medication has and what's the general risk of those kind of side effects. And so I sort of counterbalance drugs in that way. And there are specific interactions too, but the biggest things are those common side effects.
How do people find a psychiatrist who's good at, if they're, say they have bipolar disorder, what kind of questions would they ask?
Luckily in the Bay Area, I think we have a better chance. I've traveled around the country, and it's not homogeneous in terms of the excellence of psychiatric care we have here. I think the Bay Area has been pretty good, and I think, to our own horn at Stanford, I think it has to do partly to do with the fact that about 15 or so years ago, Stanford Bipolar Disorder Clinic was started, and so we try to do a big educational piece. And so I think there's really a lot of understanding of bipolar in the area. I think the biggest thing is to figure out if people actually look for bipolar disorder when they think of depression. And I think it's so important to do that because there's so much depression, and it's sort of the bread and butter of seeing a psychiatrist. That's the most common reason to see a psychiatrist. So I would say, how often does somebody look for bipolar? If they say, yeah, I don't see bipolar that often, that's probably not so good. Okay? But if they say, I don't know, I look for bipolar every single time, okay, which they should, then I think that's really the thing to do.
Okay, good. Can you tell us what other things besides medication that you recommend to your clients?
Yeah, so I think the medications are only half the piece, and it's actually the easy part. Because you just put it in your mouth and it does its thing, right, or not. The therapy is the part that you do every single minute if you can, or every hour or every day. So it's up to you, okay? And we can sort of coach along those lines, so that's where we recommend it a lot. The other thing is we don't want patients to miss their medications, but they do, okay? But they don't really miss their therapy, right? Because it's always there working, right? And so we actually ask them to do therapy. Now, because I specialize in medications. When I do therapy, I usually tell people to do the basic one, which is, I tell them to do what we call as social rhythms therapy, which is, it's kind of simple. They have to have a regular routine. Go to bed at the same time, wake up at the same time, have good social interactions every day, okay, kind of a routine that way. And Robert gave some good examples of that, of why that's important. One is so there's routine, and secondly, because when you're off that routine, you know something's not quite right.
Right. I have some resources you may want to go for more help. The first is NAMI, the National Alliance on Mental Illness. We mentioned it a few times. They have the program that Robert is a trainer of called In Our Own Voice. It's a sort of a speakers bureau, people who have bipolar disorder and are telling their story. And there's a lot of information on the NAMI website about bipolar disorder as well. The second organization I'd like to mention is the Depression and Bipolar Support Alliance, or DBSA. It's at dbsalliance.org. It's a patient-directed national organization, and there are lots and lots of support groups throughout the United States, and you can find one locally. Finally, I'd like to mention the Stanford Bipolar Disorders Clinic on bipolar.org. It's operated out of the Stanford University School of Medicine, and that clinic handles clinical treatment, manages clinical trials for medication, and of course teaches doctors how to become a psychiatrist. So those resources would probably be a good place to start if you want more information. To end the show, I'd like to thank you very much, Robert and Dr. Wong, for being our guests today. And the closing words are from the Reverend Wayne Arneson. Take courage, friends. The way is often hard, the path is never clear, and the stakes are very high. Take courage, for deep down there is another truth. You are not alone. Thank you for watching, and we'll see you next time.